Thank you, Dr. Carmichael. Thank you to Southern Medical for asking me to be here today, and especially to Dr. Carmichael. Yes, I'm one of the beneficiaries of the work that Dr. Carmichael's done in Southern Mississippi, and specifically at Hattiesburg Clinic. He's left a mark on Southern Mississippi, and even though he retired in 2008 from clinical practice, that mark is still there. It's not infrequent that I will see a patient and want to change a medicine on them, and I will have someone say, "Can you run that by Dr. Carmichael?" And of course I say I will, and so thank you again for all that you've done and all that you will continue to do. Today we're going to talk a little bit about hypertension in 2015, and to set the context, going to give a little bit of a historical perspective. I gained some historical perspective in my training. I spent the last year of residency. I was awarded a fellowship, and I was able to study in London and Oxford. So it gave me a good appreciation for historical aspects of care, and to give you a little bit of historical aspect of care on hypertension, we're going to look back to 1931 with Dr. Hay. Listed in the British Medical Journal, his comments on hypertension, that the biggest danger in blood pressure lies in its discovery, because then some fool will try and reduce it. Well, I stand before you today as a fool who's made a career out of this, and we're going to talk a little bit more about how things have changed since 1931. Hopefully, you've had a busy couple of days. Hopefully I can give you some practical and useful information as you wrap up your conference. We're going to look at the evolution, measurement, and treatment of hypertension, and then briefly, very briefly, look at JNC-7, look at the clinical trials that have occurred since JNC-7, and then look at JNC-8 and things that have come out since JNC-8. So it's kind of a walk through time. So first, looking at the evolution, measurement, and treatment of hypertension. And, you know, Dr. Carmichael asked me, you know, how did you get interested in hypertension? How did this become a career choice for you? Well, I think the stars aligned when I was at UMC. I still was able to have Dr. Guyton as my physiology professor. So he was the one at my physiology lab when we were studying hypertension who was the one telling me what to do when we were studying hypertension in the pigs. And then further on in my training, Dr. Dan Jones was chairman of the hypertension department at that time. He went on to be an author of JNC-6, later president of the American Heart Association, then dean of the University of Mississippi. So those two individuals had a big impact on I guess, my likes and dislikes, and so that's kind of how hypertension became a part of my life and my training and my work now. So as we look at the evolution, it goes back further than 1931. We talked about Dr. Hay in 1931, but you really have to go back to 1733 when Reverend Hales started measuring blood pressure. Well, he didn't measure in humans. You can see in this picture that there's a red column of tube coming up from that horse. The reason it's red is because it's blood. That was how someone first identified that there's this pressure inside the cardiovascular circulatory system. Reverend Hales catheterized the carotid, basically, and saw that pressure rose in this column of tube in 1733. Well, move forward a little bit, 1828, John, we can debate heavily how this is pronounced. I grew up in the Mississippi Delta. This is pronounced one way. Then I went to LSU undergraduate. I had a French professor and a French Cajun professor, and neither of them said it the same way. So Poiseuille's law in my training as a petroleum engineer was very important to me as a petroleum engineer. Little did I know in my medical career it would come back. Poiseuille identified that we could measure this pressure but not have to put it in a tube of blood. There were different ways, and we could use manometry. And the first mercury manometer was born in 1828, and in Paris. Keep an eye on all the different parts of Europe that were involved in this blood pressure phenomenon. Moving to Berlin, 1848, Ludwig advanced things with a chymograph. So how do you measure it? We finally got a needle, that we could actually look at a needle to measure this pressure. Then on to Italy, Rivarocci developed the cuff-based sphygmomanometer. So we could actually put a cuff on a human's arm, use the needle previously identified, and measure the blood pressure a little more easily. So now we've come up with a very efficient way to measure blood pressure in a human, but what do we do with it? In 1900, the British Medical Journal claimed by using sphygmomanometry, we pauperize our senses and weaken our clinical acuity. That we shouldn't use this tool. In fact, it is weakening us as clinicians. Korotkov, we're all familiar with Korotkov now. In 1905, he identified that using this Riva-Rocci cuff, that there were sounds that we could auscultate with our ears and our stethoscopes, and that Korotkov sound, when we first heard it, was the systolic blood pressure, and when they disappeared, the diastolic blood pressure, even though they didn't call it the diastolic blood pressure in 1905. Then, in 1911, someone started to figure out that maybe having a higher blood pressure was not a good thing. So Dr. Fisher, in 1911, was quoted as saying, "The sphygmomanometer is indispensable in examinations. And the time is not far distant when all progressive will require its use in all examinations." Is anyone familiar with who Dr. Fisher is? I'll fill in the blanks for you. In life insurance examinations and progressive insurance companies will require its use in all examinations. So the insurance industry started to recognize this before the medical industry did, that having a higher blood pressure might be a bad thing. 1911. He was the medical director of Northwestern Mutual Life Insurance Company. Then, shortly after that, in 1925, the Actuarial Society of America also noted mortality increases rapidly with the increase in blood pressure over the average. Yet, in our textbook, The Practice of Medicine, in 1946, you see this was 20 years later, our medical practice textbooks said, "May not the elevation of systemic blood pressure be a natural response to guarantee a normal circulation to the heart, brain, and kidneys? Overzealous attempts to lower the pressure may do no good and often do harm. Many cases of essential hypertension not only do not need any treatment, but are much better without it." 1946. Then the landmark trials came in 1967. Dr. Fries with the VA cooperative study, small trials to begin with, just 143 patients, where some received active treatment to lowering blood pressure. What they found in 1967 was that there was a significant reduction in stroke, coronary events, heart failure, renal damage, and death by lowering blood pressure. Not until 1967. But since 1967, things have changed rapidly. The JNC, Joint National Commission, has been charged with giving blood pressure guidelines and recommendations to clinicians throughout the world. You can see their first guidelines came out in 1977, and these look at systolic blood pressure. Interestingly, you will see that the first two permeations of JNC did not mention systolic blood pressure. They did not think it was important at all. It was all about the diastolic back then in 1977. And then later, 1980s, you see JNC2, and then 84 and on, you can see the evolution of how systolic blood pressure was identified and the recommendations that were given after that. So you can see in JNC-7, we identified a new term called pre-hypertension. That's since fallen a little bit out of favor, but a nice evolution through the years on how important it is to lower blood pressure and what we classify it. Similarly, with diastolic blood pressure, the more important of the two back in the 1970s was they said to consider therapy if the diastolic was 106. Less than 106, don't even really consider it. You can see as we move forward, the diastolics have also progressed, where we have started to move the diastolic goals a little bit lower through JNC-7. Despite where we've come since the 60s in the VA cooperative studies, we still have a long way to go. You can see the most recent data from 2012 from the CDC so that about 30% of the American population has hypertension. However, over half of those patients remain uncontrolled, controlled to less than 140/90 in these slides. So a third of the population, roughly, have hypertension, but of those, less than half are less at 140/90 or lower. So controlled, we've got about 31 million patients. Uncontrolled, we've got about 36 million patients. Of those that are uncontrolled, the green box, 16 million of those patients are aware they have hypertension and are treated for their hypertension, and they are uncontrolled. Aware, the second box, 5.7 million, yet untreated. They know they have hypertension, yet they are untreated for their hypertension. 5.7 million individuals. Then we have an additional 14.1 million individuals who are completely unaware that they have hypertension at all. A big burden for us as we try to tackle the cardiovascular disease in the United States. So that's where we've been. That's where we've evolved since the measuring of the blood pressure rise in a heart in the neck of a horse. So what's happened since JNC-7, and what did JNC-7 tell us? Remember, quickly, that JNC-7 qualified normal blood pressure as being less than 120/80, but identified a new category of pre-hypertension with systolics between 120 and 139, or a diastolic between 80 and 89. Then moving on to stage 1 and stage 2 hypertension. The other thing that JNC-7 did that was different from the prior versions of JNC was to say that for stage 1 hypertension in your far left, that thiazides were appropriate for most patients, but basically you can use whatever you want, but thiazides were appropriate for most. The other thing that they did that was new for stage 2 hypertension patients was to say that we could use 2 drugs at the same time at the outset of therapy. When I was in training, we were trained, start 1, titrate as high as it would go, and then add number 2. We were never allowed to start 2 drugs at the same time, even if a systolic blood pressure was 200. This was a new recommendation from JNC that we can and should use 2 drugs at a time at the outset of treatment if the patient has a systolic blood pressure, in this case of 160. With compelling indications, they deferred if basically this was deferring to the other societies. If the cardiologist wants you to use a beta blocker, there are some indications for that. If the nephrologist wants you to use an ACE or an ARB, certainly there are indications for doing that. So giving an out for those compelling indications. And then recommendations on how to titrate therapy. Again, that was brief. I said we'd get through those quickly. But more important from JNC-7 is as soon as JNC-7 came out, trials were designed to refute the recommendations. Very clearly, many of the major trials that were put out there after JNC-7 were specifically designed to challenge the ideas of JNC-7. We're going to go through these really quickly. As I said, the most recent report, JNC-8, came out in 2013, late 2013. So there was this gap between 2002 in 2013 that we had a lot of clinical trials coming out. They were really designed to challenge what are the goals of treatment and what drugs should we use to lower the blood pressure. There are a lot of trials. We're not going to go through all. I picked a few. I picked these because they really were new ideas that brought something new to the table since JNC-7. The ASCOT trial challenged the idea that thiazide therapy was appropriate for most patients, and that beta blockers were really good for patients with cardiovascular disease. What they did in the ASCOT trial was to pair a calcium channel blocker ACE-based therapy to the beta blocker thiazide-based therapy. And what they found was that the calcium channel blocker ACE arm did far better than the thiazide beta blocker arm, very much contrary to what JNC-7 recommended. The Camelot trial gave medicines, both calcium blockers and ACE inhibitors, to patients who had normal blood pressure but documented coronary artery disease. So the Camelot trial was challenging how low should we go. These people with cardiac disease had normal blood pressures, yet with therapy, lowering the blood pressure a little bit further, they had improved outcome with calcium blockers and ACE inhibitors. The Trophy trial was an interesting one. These were patients who had prehypertension, normal blood pressure. These people were treated with ARB therapy and then followed up after that ARB therapy was discontinued 3 years later, and they had a lower incidence of hypertension 10 years down the road. So they had something happen to their physiology that pre-treating them, quote unquote, if you will, might have changed their outcome later down the road. Many trials examine the beta blockers. And what they discovered in those trials was that the beta blockers were quite heterogeneous in their outcome. That selective beta blockers, such as atenolol, may not have as much protective effect as the non-selective beta blockers. A big series of trials showed that while we're lowering blood pressure with atenolol, we may not be helping people live longer, as opposed to the non-selective beta blockers who may have cardiovascular benefit. The Accomplished trial. This was a very interesting trial. It went on the presumption that everybody needs an ACE or an ARB. The question they asked is, what should you add next? So if I start with an ACE or an ARB, do I add a thiazide or do I add a calcium channel blocker? And what they found was the ACE calcium channel blocker arm did far better than the ACE thiazide arm. Most recently, the Accord trial looked at diabetic patients, pushing those blood pressures very aggressively to less than 120, and it did not show a reduced rate of cardiovascular events as compared to standard blood pressure guidelines at less than 140. However, they did have a lower stroke incidence. So you have to look at the summation of these trials and ask, is the key to all this blocking the renin-angiotensin-aldosterone system? Because a lot of the trials that came out of after 7, JNC-7, were really pushing that question. Is the RAS blockade the key to this all? So a couple of trials answering, or at least asking that question specifically, was the ONTARGET trial, where these were high-risk patients who had normal or controlled blood pressure. They they were followed for 6 years for these outcomes, either cardiovascular death, MI, stroke, or heart failure hospitalization. And they asked, is the ARB telmisartan non-inferior to the ACE inhibitor ramipril? And then the more important question potentially is ARB telmisartan plus ACE inhibitor ramipril better than ACE inhibitor therapy alone? If you're not familiar with this trial, you probably can assume what the results were, because we don't have a lot of ACE plus ARB therapy patients running around out there right now. The conclusion is telmisartan was non-inferior. So the ARB was non-inferior to the ACE inhibitor in similar endpoints to the HOPE trial. But it was tolerated better. However, the combination of the ACE plus the ARB did not reduce primary outcomes, and there was a higher incidence of adverse events, including hypotension and renal dysfunction. Another trial examining this question of aggressive RAS blockade was the Altitude trial. These were patients with diabetes and renal disease who were already on an ACE or an ARB, and then they were randomized to receive the direct renin inhibitor aliskiren or placebo. The primary endpoint, similar, cardiovascular death. And the question was, is aliskiren, the direct renin inhibitor, plus ACE-ARB therapy better than the ACE-ARB therapy by itself? Again, you may not know the exact results of this trial, but we're not seeing a lot of patients with aliskiren plus ACE therapy anymore. Here are the results. This trial was terminated early due to an increased risk of non-fatal stroke, renal impairment, hyperkalemia in these diabetic patients who were given aliskiren plus the ACE-ARB therapy. And in 2012, they changed the label of aliskiren to say that it was contraindicated in diabetic patients who were also on ACE or ARB therapy, and the warning to avoid it in combination in GFRs less than 60. And in July 2012, Valterna, the trade name, which was aliskiren plus valsartan, became no longer available. You can see a big evolution that after JNC-7, a lot of trials were pointing us toward ACE-ARB being the core of hypertension therapy. But when you extend that beyond to aggressive ACE-ARB therapy, maybe the results aren't quite as similar. All right. So that brings us to our most recent guidelines, JNC-8. As I said before, JNC-7, between JNC-7 and JNC-8, there was a span of 11 years. So the trials were questioning the appropriate goals for therapy and what are the appropriate medications. We're going to look first at the appropriate goals. This is a schematic, a flow chart, if you will, of JNC-8, also called JNC 2014. We're going to look first at the top half, which is asking the question, what is my goal for blood pressure? This is a very different approach than what we've previously taken to hypertension treatment and therapy. The first question we have to ask ourselves in determining a patient's goal blood pressure is, do they have diabetes or chronic kidney disease? And if they do not have diabetes or chronic kidney disease, we have to ask ourselves a new question that we've never asked ourselves in a treatment algorithm for hypertension, and that is, how old is the patient? So in the patient who has no diabetes or chronic kidney disease, if they're 60 or older, our goal blood pressure is recommended to be less than 150/90. I don't know about you, but I got a lot of phone calls when this hit the press from my elderly patients who were telling me to get off their back, basically, because I'd been hammering them for years and years and years that we needed to get less than 140/90. This, according to JNC-8, suggests that maybe we don't have to push that low. This was based on clinical trial data, some of which you may be familiar with, the seniors trial, the HIVET trial, looking at the patients in the older age groups. So the goal, according to JNC-8, for 60 and over now should be less than 150/90 if they don't have diabetes or CKD. If they're less than 60, 140/90, we kept our same goal for those patients. Now turning to the diabetic or CKD patient. If the patient, regardless of age, has diabetes but no kidney disease, the goal is less than 140/90. Somewhat new recommendation as well. If the patient has chronic kidney disease with or without diabetes, 140/90. So our only group, as you scan the screen here, the only group that does not need less than 140/90 is the 60-plus-year-old patient who does not have diabetes or CKD. Notice nowhere on this slide do you see the numbers 130/80. Turning now to what medicines should we use. Remember JNC-7 said thiazides for most, but pretty much pick whatever you want. Let's stick with our diabetic patient, our CKD patient who may or may not have diabetes. If they've got CKD, regardless of their race, we should use ACE or ARB therapy for that patient. So So CKD is the key to what drugs to use. Notice missing here diabetes. It says specifically CKD with or without diabetes. Here, the patient who has no CKD but diabetes is grouped with everybody else. So no CKD but diabetes is grouped with everyone else. And then you ask yourself another new question. What is the patient's race? They are non-black, thiazide therapy, or ACE, or ARB, or calcium blocker, or combination therapy. If they're African American, initiate thiazide diuretic, or CCB, or in combination. So if you follow this through, there's some interesting things that come out. If they are a diabetic patient who is African American, this recommends using thiazide therapy, not ACE-ARB therapy, like we previously were taught. Diabetes needs ACE-ARB therapy. Only the CKD patient needs that. And then the recommendation to titrate therapy as needed based on blood pressure response and adding more drugs. The bottom half of this graph really focuses on what do you do if you start that drug, that second drug, that third drug, and they're still not at goal. You basically keep adding the second, the third, the fourth drug until you can get them to control. The key that we've got to remember with hypertension, and this is an important point we have to convey to our patients, is that we cannot control hypertension with one drug, especially not in the southeastern part of the United States, and especially not in South Mississippi. It takes, when you look at these trials, to get to diastolics less than 90 and systolics less than 140, it takes 2, 3, 4 drugs. And if we go into a conversation with our patients, giving them the expectation that I'm going to be able to give you this one medicine and your blood pressure is going to be better, then we're not giving the whole story there. We've got to outline to them that this is going to take 2 or 3 or 4 drugs. That does two things. It sets the patient's expectations, and it gets you off the hook a little bit so that they're not thinking, we don't know what we're doing. We know it's going to take 2 or 3 drugs. So we need to have that conversation with the patient up front. We also know that if they engage and adhere to a low sodium diet and lose weight, maybe it won't take those 2 or 3. So allowing that bartering, that partnership to say, you're starting at 180, I'm trying to get you to 140. Every drug's going to lower you about 10 to 15, so you're going to need 4 drugs, unless you aggressively work on your sodium intake, work on your exercise, and remove some of those other factors making your blood pressure higher. Those are important conversations we have to have so that the patients understand what is about to happen. Despite all that, we sometimes don't get to go even with 3 or 4 drugs. And we have to evaluate, is there something else going on with this patient? Is there a secondary cause? Is there something influenced their blood pressure? And so on. So JNC-8, very, very controversial for lots of reasons I pointed out, both the blood pressure goals and the medications chosen based on your age, your comorbidities, and your race. Very recently, last month, some new information came out called the SPRINT trial. I don't know if you're familiar with this. This has hit the headlines quite heavily. A trial of over 9,000 patients who were not diabetic but had cardiovascular risk. So they had risk factors for cardiac disease. And what the SPRINT trial has been promised to say, notice I didn't say it says yet because we don't know, the release from the NIH said that we have proven that lowering blood pressure to less than 120 is beneficial. in these 9,000 plus patients. A very, very different message from what we learned in JNC-8. So just last month, everything's confused again. So that this trial suggests in non-diabetics, 50 years of age and older, that a goal blood pressure of less than 120 might be appropriate. This was another Forbes article that I think is appropriate. When this news came out, NIH, everybody's really excited, but then the doctors started to weigh in and say, wait, hold on, what's going on? Why are we annoyed with this? One of the reasons is because they didn't release the specifics of the trial. They closed the trial early, we don't have safety information, and we don't have all the specifics yet of what this trial means. We just have this message that 120 is where we should be going with 50-year-old non-diabetics, but we don't have the specifics. So yes, we're frustrated. We don't know the real answer. I would encourage you to look at this Medscape video from Drs. Black and Dr. Cushman. Dr. Cushman was one of the investigators on the SPRINT trial. This is a very, very good summary of the SPRINT trial. And it speaks to some of the controversy of why are we not jumping on, we as practicing clinicians are not jumping on to this message completely just yet. We are supposed to learn more about the SPRINT trial November 9th at the ACC, and then the full report is supposed to come to us sometime before the end of the year. So this is a lot, this is hot off the press, this is very controversial at this point, and a lot unknown. So what do? We're stuck in the middle again, with guidelines telling us different things. I wish I had an answer for you, because I'm this guy too. I'm struggling, because my patients are hearing this information, and they're asking me, and I can't give them an answer just yet. I will offer up for your consideration my approach. Generally speaking, I start ACE/ARB therapy on most of my patients, even the African American, knowing that I might need higher doses. These are well-tolerated medications for the most part, and I choose them as first line. Personally, I choose them as first line for most of my patients. Calcium channel blocker therapy is very complementary to the ACE/ARB therapy. Thiazide is as well. Then we move into the beta blocker world, especially if they have certain indications. And aldosterone blockade continues to work its way up this list. Not long ago, it was down 9 or 10, but it's moving its way up, not just in my approach, but in standard medical literature for refractory hypertension. Aldosterone blockade with eplerenone and spironolactone. Direct vasodilators are moving further. Alpha blockers are moving way down this list. Sympatholytics, even further. And that is a general approach. The key is, where we get into trouble is when we try to generalize recommendations for a population to the patient sitting across from us in the exam room. And every patient is a little bit different, and every patient brings a new different set of circumstances to the table, and we've got to investigate and evaluate what that patient brings. So, yes, while this may be a general approach, these are the things that we've got to think of on that individual sitting across from us. For that ACE or ARB, obviously avoid it if pregnancy is a possibility. You may need a lower dose in the low renin patients. These are generally African American patients who need higher doses of ACE and ARB therapy. And don't forget to check that potassium and creatinine 2 to 3 weeks after starting your ACE or ARB therapy. Calcium channel blockers, the dihydropyridines are preferred unless the patient has a comorbidity like migraines or palpitations that you may be able to help them with some non-dihydropyridine. Thiazide diuretics, still great therapy. We use HCTZ a lot. Chlorthalidone is a much better blood pressure agent as far as a thiazide diuretic goes. It's got a longer half-life and it's got more potent blood pressure reduction. It's just a whole lot harder to write on a script pad, HCTZ, and that's really why we have moved in that direction. Be careful with thiazides in patients with gout or sulfa. I mentioned here chlorthalidone is preferred due to a longer half-life. Be careful about using loop diuretics like furosemide for hypertension therapy because they have a short half-life. If you're dosing furosemide in a patient with a normal GFR for hypertension, and if you're only dosing it once a day, you may be making their blood pressure worse in the afternoon, evening hours. With the short half-life, you're causing a vasoconstrictive high renin response in the afternoon, and their blood pressures escalate in the afternoon and evening hours because of its short half-life. So if you're going to use furosemide or a short half-life loop diuretic for hypertension therapy, I ask you to try to use it twice a day. That's challenging. So when we do that in our clinic, we try to do an early morning dose and then a 2 to 3 p.m. dose to try to stretch them out. Obviously, nighttime dosing, not preferable for those loop diuretics, but we have to be careful in using those medicines for hypertension treatment alone. Beta blockers, be very careful in use with non-dihydropyridine calcium channel blockers. This one is often missed. We see patients all the time who are on a verapamil or diltiazem and a beta blocker. Be very, very cautious about that combination for risk of heart block. Use sooner if there's a clinical indication such as CAD, congestive heart failure. And I mentioned previously that non-selective beta blockers are preferred due to their better metabolic side effects. We also know there have been some very good trials to show that the non-selective beta blockers are more effective in patients with sleep apnea. We have a lot of sleep apnea in Mississippi, and I suspect you do as well. Non-selective beta blockers do better for blood pressure in those sleep apneic patients. Aldosterone blocker also works well in combination with HCTZ in sleep apnea, but be very, very cautious about the use of spironolactone or eplerenone primarily because of the hyperkalemia. In my patients in the summer, I'm checking labs more frequently on my patients who are on spironolactone. They get dehydrated, they get hot, they eat their tomatoes, and they put light salt on them. So they've got a potassium load and their potassiums go up. So we have to be careful with this medicine. Also, caution your men, counsel them about gynecomastia. It does occur. Eplerenone, thankfully, is not as expensive as it used to be if you get gynecomastia with spironolactone. Direct vasodilators can cause reflex tachycardia, minoxidil, hirsutism, etc. Alpha blockers are a good option for men with BPH, but they have interactions and they should never be used as monotherapy. Sympatholytics, guanfacine, been around for a while. Better than clonidine due to its longer half-life. And the clonidine patch is an option for patients with rapid GI transit time. So that cyclic vomiter, I've got a couple in my practice, so that their blood pressure is well controlled until they get into their cyclic vomiting syndrome or they have a rapid GI transit time, and then you're stuck because their blood pressure is great until they get into a cyclic vomiting syndrome. So that patient, a clonidine patch is nice to have on hand for that patient when they start their cycle. So these are all the thoughts that go through my head. Heaven help you if they go through yours every time that you're seeing a patient. But then you go through all this and you still have those patients who you can't get controlled. And I add one more thought at the bottom, SSRI therapy. And this is serious. And I don't know if that's meant that I want myself to take an SSRI or to give it to the patient, but SSRIs and SNRIs are good blood pressure drugs in the right patient. There is a real phenomenon called pseudopheochromocytoma. How many pheos have we looked for and never found them? but they're those patients who get so upset when their blood pressure is high, start checking it fanatically, and what does it do? It just escalates their blood pressure. And of course they're going to get flushed, and of course they're going to have palpitations. They're having a panic attack. It's not a pheo. It's a pseudo-pheo, and SSRIs help marvelously with that specific patient. At the end of the day, with all the controversy that goes around and all the trials and all the information that keeps coming at us about blood pressure treatment, we know that lowering blood pressure saves lives, despite what 1946 textbooks might have said. We know this saves lives. For every 12 millimeters of mercury that we decrease blood pressure and maintain that over 10 years, this is a conversation I have with my patients all the time, I prevent 1 death out of 20 patients who are otherwise absolutely healthy. All I have to do is treat 20 patients that day, and one of them is going to live because we lowered their blood pressure 12 millimeters of mercury. If you have patients with coronary artery disease, all you have to do is treat 12 of them. And if you have diabetics, all you have to do is treat 9 of them. This is why we do what we do, and this is why it's important that we lower blood pressure. I mentioned to you that I was fortunate enough to have Dr. Guyton as one of my professors. For those of you who may have had him too, you know that was a double-edged sword. He was tough. In physiology lab one day, I was debating with him. I wasn't very well debating. I was asking. There was no debate. It was one-sided. Some of these questions, how low to go? What drugs to use? And very clearly, this is his quote to the word, just get it down, stupid. And he's right. Here we are in 2015, and he was right. Just get it down. We can debate what drugs to use. We can debate what is the exact number, but we know that 12 millimeters of mercury over 10 years saves lives. So just get it down, stupid, is the lesson that I take away from my interaction with him. I'll leave you with one last thought. I did have the opportunity to study a lot about Dr. Osler when I was in England. And there were 2 things that hit me that were very, very important, that meant a lot to me. Gentlemen, if you want a profession in which everything is certain, you better give up medicine. That's why we come to the office every day, because it's changing every day we do this. It's exciting, it's an opportunity, it's fun. And I'll leave you with one last thought. Medicine is the most difficult of predicaments, but to have striven, to have made an effort, to have been true to certain ideas, this alone is worth the struggle. This is what we're about. And it's a great opportunity we have every day, and I hope you continue to enjoy it as much as I do. Thank you.